Today we're going to be recording the Chapter 4 review for HIMT. This chapter is about our government-sponsored healthcare programs. Here are your objectives. And then we start off with Medicare. Medicare is a Title XVII, that would be 18 of the Social Security Act. The Social Security Act established in 1935. It was called Old Age Benefits, which was benefits to workers, unemployment, and aid to dependent children with disabilities. In 1965, it was amended to become Medicare, and it was implemented on July the 1st of 1966. Now, because we're talking about government health players, all of these are going to be mandated by federal laws and regulations. So as we're talking about each one, keep in mind that they do all go back to a federal law and regulation. So the beneficiaries, that is who can have Medicare, 65 or older. You have to be eligible for Social Security or railroad retirement benefits to be eligible. Persons with certain disabilities, end-stage renal disease, could be like an uninsured worker, spouses, and then also children with end-stage renal. If you're entitled to the Social Security or railroad disability for 24 months, you would be eligible. And if you're a government employee with a Medicare disability for more than 29 months. So this is a national health insurance program, and those are the people that are eligible to receive it. So when we look at Medicare, it has 4 parts. Now let's talk just a little bit about some back history on this. So in 2010, there were 2 major laws that affect Medicare, Patient Protection Act and then the Affordable Care Act. All of these came together to kind of make some changes in Medicare. They wanted to increase the quality of service. They wanted to support a new payment system, better align Medicare payments with providers' costs. They wanted to make the program a little bit more trusted and strengthen it. And also they wanted to position Medicare on a solid financial footing. In years past, there was a lot of fraud going on, so Medicare funds were getting low. So they started looking at how are we going to make sure that people that need these funds down the road are going to have those funds. So here's our 4 parts, and we're going to talk about each one. Part A is what we call hospital insurance. Part B is voluntary supplemental medical insurance. Part C is our managed care. It combines A and B. And then Part D is an outpatient prescription drug coverage. Now, you also sometimes hear about a Medicare Gap or Medigap, and this is a supplement that can also be purchased. It helps to pay for those cost-sharing costs like deductibles, copays, and co-insurances. So Medicare Part A is basically our hospital inpatient insurance. It is the one that has no premium for most things. There is some cost sharing, which is going to be deductibles, co-payments, co-insurance. You can look at Table 4.1 on page 82, and it shows you the cost and the benefits associated with Medicare. So you can see how much the patient's responsible for, what the benefit period is. It includes acute care, inpatient, long-term care, skilled nursing facilities, hospice, and also home health. So Medicare Part B, it is optional. You see it's a voluntary supplemental insurance. It helps to reimburse our outpatient care. So it requires a premium to purchase. That's why it's voluntary. The average premium in 2018 was $134. It has cost share and deductibles, co-payments, and co-insurances, and that's on Table 4.2 on page 83. With this, the services would be physician services, outpatient hospital like an emergency room, medical supplies not covered by A, medical services. So kind of keep in mind with this one, it is a premium, and then we pay deductibles and copays. Remember Part A, there's no premium, but we do pay deductibles and copays. Part C is what we call Medicare Advantage, sometimes called MA. This is our managed care. We are going to talk more in Chapter 5 about managed care. But Medicare Part C, it combines Part A and B. and it also does provide some of the Part D. So it's available if you are enrolled in A, B, and D. It requires a premium. It does have some cost sharing provisions depending on what plan that you are looking at. So A and B does exclude some services. So they say that this Part C, the managed care, does increase the benefits. CMS posts quality performance ratings to help beneficiaries decide which managed care plan they want to go into. They give a rating of 1 to 5. Anybody with a 4 or higher is eligible for bonus payments from Medicare. And it does expand the scope of service that's included in Part C. So you're going to see some custodial care, dental services, some vision, health and wellness, such as your routine exams, health exams. Acupuncture is covered, and also hearing aids are covered. And those bullets are on page 83 that kind of go along with that slide. Now, Medicare Part D was created in 2003 and implemented in 2006. It is an outpatient prescription drug benefit. It's administered by private prescription drug plans and Medicare Advantage. It has a premium, a deductible, and a copay. Now, the premiums may be as low as $13 a month. There are some low-income provisions built for the copay. It helps with any of our outpatient drugs, and it increases your access to pharmacies that stay up to date with your formularies, the drugs that they can help you get at a discounted price. Medigap, this is our supplementary insurance. It covers services not covered by Medicare. It's kind of helps to cover those cost sharing. So some people buy this as a supplement to the others to help pay for the co-pays, the deductibles, and the co-insurances. There are several different insurance providers that offer a Medigap, and there are federal guidelines that must be met for those Medigap plans. Now, Medicaid, remember CMS is made up of Medicare and Medicaid. Medicaid was originally a medical assistant program. It falls under Title X1X of the Social Security Act, and it was added in 1965. It provides benefits to individuals and families with low incomes and limited financial resources. It is a joint program between federal and state, and it's administered by each state. So each state can decide what the eligibility is, what type, the amount, duration, scope of services. So the coverage is going to vary by state to state. Qualifying in one state does not guarantee that you will qualify in another state. The program does cover infants that are born to a Medicaid-eligible pregnant woman. So if a pregnant woman was eligible while pregnant, that infant would also be eligible. The federal funds that are allocated to each state are based on the average income per person for that state, and it's important to know how that is funded. On pages 82 and 83, remember that that's where you can kind of see that comparison of the benefits for your Medicare. There's a little bit of information in those so that you can kind of see with that what Medicare covers, and know that Medicaid picks up more because it's looking at those low income areas. All right, a little bit more about Medicaid requirements. It does for each state. Remember, each state is responsible. It's a state program. The state can also offer a managed care. They can set it up how they want, but they have to provide coverage for these people listed here. That's the way that they get their federal funds. So it has to be poverty-related infants, newborns, pregnant women, low income, less than the state limit, families that are receiving transitional medical assistance, children with a Title IV-E adoption assistance, foster care, or guardianship care, children aging out of foster care, elderly and disabled individuals that are receiving Social Security incomes, aged, blind, disabled individuals who live in 209B states, certain working individuals with disabilities, certain low-income Medicare enrollees such as specified low-income Medicare beneficiaries. That's the SLMB. There are some special eligibility groups that cover children with long-term disabilities. Those are listed on page 84. In addition, states must offer a designated set of services. Those services are found in Figure 4.1 on page 84. Eligibility and services can be expanded based on state laws. And remember, the federal law does allow for expanded eligibility, but it's up to the states on how they expand that. Page 85, there's some bullets there that list some optional groups that could be people that could be added in to those specialty services. Now, our programs for all-inclusive care for the elderly, that's PACE. This isn't in all states or all areas. It was started in 1997 as part of the Balanced Budget Act. It is a joint Medicare-Medicaid venture, and it offers the states the options of creating and administering a managed care option for the frail elderly population in the community. It enhances the quality of life for frail population. It enables them to live in their own homes and communities. Now, in order to be eligible, each state has to have a service facility that's in various geographic service areas. They have to have increased accessibility to the frail elderly population. So if you're eligible for Medicare and Medicaid, you can join PACE. In order to join PACE, you must be 55, live in a PACE service area, require nursing home level care, be able to live safely in the community by yourself. Every facility has to have what they call an interdisciplinary team, which is going to have a primary care provider, that's your PCP, your RN, social worker, PT, OT, recreation therapist, a dietitian, a PACE center supervisor, a home care liaison, a driver, and a personal care assistant. On page 86, figure 4-2, it does show you some of the requirements that in order for the funding to be received, those PACE areas those facilities have to have those required services available. Now, keep in mind that PACE isn't available in all states, and PACE enrollees do sometimes have to go to the facilities, and that's going to be determined based on their needs and the decision by that interdisciplinary team. There are certain areas a state may have a PACE team, but it may not be available in all areas in that state. So next is the Children's Health Insurance Program. And again, remember, all of these programs are government funded federal programs, so they're getting federal funds. So we have CHIP, which is from the Title XXI 21 of the Social Security Act. It was also created by the Balanced Budget Act and started in 1997. Now, this one is important to remember that it's a state and federal partnership. It targets the growing number of children that are not covered by health insurance. Like Medicaid, CHIP does vary from state to state. It varies on the requirements, and there are requirements for limiting cost sharing. So they say that it can be no more than 5% of the gross or net that you would pay a year for your cost sharing. American Indians and Alaskan Native children members of a tribe, there's no charge for them. So states have to provide these services for CHIPs. They have to have an inpatient hospital service, outpatient hospital services. They have to have physician, medical, and surgical services, lab and radiology services, well baby child care services with immunizations, and then they also have to provide dental services. Currently, there are about 9 million children that are enrolled in CHIP. We provide health insurance to children of families whose income is too high for Medicaid but too low to afford health insurance. The child has to reside with a family that is at or below the federal poverty level. Again, each state determines requirements, how they deliver that plan. Medicaid eligibility is taken into consideration. Whatever the design is, CMS is responsible for approving that state plan and making any revisions to it. Now, next we have TRICARE. TRICARE is a division of the Department of Defense. It did replace CHAMPUS. It is for active duty members of the military and qualified military members. It looks at retired members, it looks at survivors, it looks at families, and it looks at 7 of our uniformed services. It also looks at activated guards or reserve members. Comprehensive coverage is outpatient visits, hospitalizations, preventive care, maternity, immunizations, mental behavioral health. There are several plans to choose from, and it kind of depends on where you are as far as in your military status as to which plan you can actually take on. So our next slide is going to look at the different options. Now, there are some abbreviations up at the top there. ADSM, if you see that, that's active duty service member. And then ADFM is the active duty family member. So several different options. We have first option there is the TRICARE Prime and the Prime Remote. You can see it's for ADSM and ADFM. This one has no enrollment fee. There are availabilities for retirees. It is the most economical because of the no enrollment fees. TRICARE Prime and Prime Remote are managed care options. All active duty and activated guards automatically are covered. They have to complete and submit an enrollment form to their regional contractor. The TRICARE Prime does require an ADSM to live and work 50 miles or less less than an hour drive from a military treatment facility. TRICARE Prime Remote is required when the ADSM lives and works in a remote area, and you can use out of network if there's no in-network person that's available. There's also Prime Overseas and Prime Remote Overseas. Both of these require that the member and the family are located overseas. I needed a bigger slide for this one. We also have something that's called the U.S. Family Health Plan. It's a component of TRICARE Prime. It's available to active duty retirees and their family. If they're over 65, they can participate regardless of if they're in Medicare. They have 6 regions of care centers in the United States. If you sign up for the U.S. Family Health Plan, you can go to a Medicare facility, a military treatment facility, TRICARE provider. You receive care from a PCP who then will coordinate your care, and they will send you to wherever you need to go. So one of the things to remember about TRICARE Prime and Prime Remote is that there's no enrollment, there's no deductible, and there's no copay as long as you have authorized services or authorized prescriptions. So that kind of makes it why it's the most economical for military families. You do have to sign up for Prime during enrollment. Now, our next bullet talks about TRICARE Select and Select Overseas. And this can be for family members. The family doesn't have to enroll. They are kind of included in something that's called the DEER. That's the Defense Enrollment Eligibility Reporting System. What it does is it determines what you're eligible for, and it's your responsibility to keep that up to date. Now, this one does have an outpatient deductible as well as cost sharing. It has a copay, it has a co-insurance per day for hospital stays. Retirees that are less than 65 with families may enroll in the TRICARE Select. Again, they have those copays, those co-insurances that are included with that. Next is the TRICARE Young Adult. This is for family members that are children of members or retirees that are 21 to 25. They have to be unmarried and not eligible for employer-sponsored health insurance based on their own employment. There is premium-based, it's cost sharing. There is a Young Adult Prime, which allows for a lower cost sharing and free care at some military treatments. There is a Young Adult Select, has a higher co-insurance, but there is more flexibility. Next, we have TRICARE Reserve and Retired. This is for qualified National Guard and Reserve members. This is premium-based plan. It's for individuals. There's a family plan. It does have a copay and a coinsurance. A little bit higher premiums, and copays. The reserve does include a dental, which is also based on your pay grade and service area, with again premiums and copays included with it. Then we have TRICARE for Life, which is a secondary coverage for those that are eligible for Medicare. TRICARE would be secondary to Medicare, so it minimizes the cost of those deductibles. It's similar to our Medigap, which is that supplemental. All eligible TRICARE and Medicare kind of work together to make sure that that's in the best place. Now, when we talk about reserves and families, if the reserve is moved to active duty for more than 30 days, they are eligible for TRICARE, but they must enroll in that first month that the person is been activated. Our Veterans Health, VA, this is the nation's largest integrated health system. We have about 1,700 care sites with about 9 million veterans serviced each year. It is a little or no cost, and in order to be eligible, it has to be a veteran who was in active duty and had a normal separation, so it couldn't have been a dishonorable separation that would make you not eligible. You could be a former reserve, National Guard, anything where you had about 24 continuous months of activity makes you eligible for veteran services. Now, whenever you enroll, you're going to be placed into what they call a priority group. There are 8 priority groups, and you can see those groups on page 89, figure 4.3. Private insurance can be used to supplement your VA, and that doesn't affect your VA. Again, that's like that Medigap. It helps to cover those copays. It's just a supplement. Copays, non-service conditions, when enrolled, they do a financial assessment that kind of helps to determine what level of copay they believe that you can pay, and then that's updated yearly if something was to change. Next, we have HIMT, which is our Civilian Health and Medical Program of the Department of Veterans Affairs. This covers services and supplies to eligible beneficiaries. Who would be eligible? It's spouses, widows, children, vets that meet certain criteria. So some of the criteria are listed on page 89. Permanently and totally disabled due to a service-connected disability. At the time of death, the veteran was permanently and totally disabled due to a VA-rated service connected condition, died of a VA-rated service-connected disability, or died on active duty not due to misconduct. And those are on page 89. There's some bullets there right down below the priority groups. So it's dependents and survivors of permanently and totally disabled vets, survivors of veterans who died of service-related conditions, or survivors who died in the line of duty. Now, one thing that's important, if a family member is qualified for TRICARE, then they cannot enroll in CHAMP-V, so you can't have both. Enrollees are treated at participating VA health care facilities, covers those services and supplies. There's an outpatient deductible and some cost sharing, so it does have a deductible. If you have another, like a private insurance, CHAMP-V would be considered a secondary. Next, we have the Indian Health, or the IHS. This was created to uphold the federal government's obligation to promote healthy American Indian and Alaska Native people, communities, and cultures. It works with the American Indians and Alaska Natives to cover inpatient and outpatient care, preventive health services, primary medical services, community health services, rehabilitative services. It even helps to develop community sanitation and facilities. They have hospitals, health centers, health stations, and residential treatment centers. It's a government-to-government relationship between the U.S. and these Native American tribes. Now, there are some functions, and it's important that you know the functions of the IHS. They are on page 90. There's some bullets there about middle ways of the first column. They assist the Indian tribes in the development of their own health program, facilitate and assist Indian tribes in coordinating health plan, promote the use of health resources available through federal, state, and local programs, and then provide comprehensive health care services. So those are important to know as far as the function of the IHS. Now, our last government program is workers' compensation. This is provided to most employees to cover health care cost and loss of income that results from a work-related injury or illness. It is legislated by individual states. They set the coverage. It can include burial, death, income, medical. Rather than contracting individually with insurance for coverage, employers pay a premium to a nonprofit workers' comp fund for their state. That allows workers' comp premiums to remain low and affordable for small business. In states where there is no workers' comp, because a state may decide they don't want to do that, employers must purchase insurance from a private carrier or provide self-insurance coverage. On our last slide, we have the Federal Employees Compensation Act. That's the FECA. This is for federal government employees. It ensures civilian employees of federal government are provided medical, death, and income benefits for work-related injuries and illnesses. Other employees can be covered under state if their state has their plan. So this was established in 1916. It's administered by the Office of the Workers' Compensation Program, which is a division of the Department of Labor. So this is a workers' comp for federal employees. Because workers' comp is state, this was developed to help those people that are working for the federal government in case they were to have an injury. Now, on your test for Chapter 4, there are 10 multiple choice questions. And they're about one of the majority of those questions, it's kind of a definition about different insurance. So there may be a question that says, which of your Medicare plans has, which one is managed care? Which Medicare plan has no premium? So those might be examples of the questions. So that's our coverage for Chapter 4. Good luck on your exam.